ऑलरेडी लेट। हाँ, पता करो क्या हो रहा है।
हाँ सर। कुछ हाँ सर। क्या हुआ सर? वो लेट तो हो गया है सर थोड़ा। सर, नहीं आपका दिख नहीं रहा। आपने पीपीटी अगर भेज दिया होता सर तो मैं ट्राई कर लेता। भेजेंगे सर। पीपीटी भेजेंगे। व्हाट्सएप पे कर देते मुझे सर। देखिए।
क्या हुआ?
फिर वो बोले कि प्रोबेबली हो जाएगा, वो ट्राई कर रहे हैं। हाँ सर। सर का वॉल्यूम रत्नेश सर अनम्यूट कीजिएगा।
हाँ हाँ, आवाज आ रही है।
हाँ आ रही है सर।
ओके।
मैं महर्षि लेता हूँ स्टार्ट करने।
आ गया।
स्क्रीन शेयर है।
हाँ, तो उसको
हाँ
लाइव
पिक्चर
करने
भी आ गया
बोलो
है
ना।
सर।
स्क्रीन
हम
शेयर।
हाँ स्क्रीन शेयर कर लीजिए सर।
स्क्रीन
नहीं,
शेयर
अभी
आ रहा है ना।
स्क्रीन शेयर तो कर रहा। हाँ,
हाँ आ
ठीक
रहा
है।
है सर।
फुल आ गया।
ओके।
उसको
मैं एक
रहने
बार
दो,
महर्षि को
मीटिंग
बोल
मत
देता
करो। उसको बोल दो लाइव जाएगा।
हूँ। यस सर। हम महर्षि मेक इट लाइव। नहीं नहीं अभी नहीं हुआ है। फिर ये स्ट्रीमिंग स्टॉप। ओके इट इज लाइव नाउ सर।
इट्स ऑलरेडी लाइव।
यस सर।
Okay. Good evening, everybody. Welcome to today's webinar brought to you by the Orthopaedic Research and Education Foundation through OrthoTV. We're sorry for the slight delay in starting the webinar as there was some problem, technical problem with Dr. Ratnesh Singh's presentation. Today we have Dr. Ratnesh Singh, who's one of the consultants in Paras HMRI Hospital. Basically, he, uh, he's going to talk about instability after total hip replacements, which is again a problem which is becoming more and more common with more and more total hips being done. So over to you, Ratnesh, and we look forward to hearing from you.
Yeah. Thank you, sir. Today I shall talk about the instability after THR. Sorry for the delay. Instability is one of the most common complication, early complication of THR, and we should always try to avoid it. What could be the etiology and what could be the type of dislocation? It could be either cranial or superior dislocation. This is usually happens in case of excessive inclination of cup, abductor insufficiency, and polyethylene wear. Dislocation usually goes along when the limb is in adduction and extended position. Another common one is a posterior dislocation. This may be due to the insufficient anteversion or retroversion of the cup, joint hyperlaxity, primary or secondary impingement. This happens when the dislocation with internal rotation and adduction of the flexed hip joint or with deflection. Anterior dislocation may happen when there is excessive combined anteversion of the stem or the cup, joint hyperlaxity, primary or secondary impingement. Position is external rotation and adduction of the extended hip joint. So coming to the risk factors, one is patient related, another is surgeon related. One is patient related where we could do very little. Female sex has high chances of dislocation, especially old fatty ladies. They have high chances of dislocation. Trochanteric non-unions are one of the cause of high dislocation rate. So we must always counsel the patient regarding trochanteric non-unions. Abductor weakness, neuromuscular disorder, and cognitive disorder. They all could be combined as neuromuscular disorders. They are one of the causes where we should think of the dislocation and plan accordingly whether we need the constrained one or the bipolar kind of implant. Previous hip surgeries carry high dislocation risk just because of the fibrosis or lack of muscles around it. Alcoholism has high, and inflammatory arthritis also has the high chances of dislocation, probably due to inflammation in the capsules and others. Surgeon related factor could be the surgical approach. This is one of the thing what we can change with our practice. Another one is the component malposition, which is most common cause of the dislocation. Head size also matters, whether you are using small head size head or large size head. The impingement, soft tissue tension, and surgeon's experience. Coming to these one by one. When talking about the surgical approaches, the posterior approach carries the highest risk of dislocation as far as the literature is concerned, but significant reduction with the anatomical capsule and muscle healing. Whether the posterior capsules and muscles has been healed properly or repaired properly, this may decrease the chances of dislocation by 7 to 8 times. This can be checked with the Ranawat test. Ranawat test can be done at 90 degrees of hip and knee flexion, and limb is put into the internal rotation. Firm end point should be less than 15 degrees. That means the internal rotation at 90 degrees of flexion should be equal to or less than 15 degrees. It suggests anatomical healing of capsule and external rotator. It is highly specific test. Alternatively, we can check the healing of the capsule by MR arthrogram. Component malposition is one of the problem. We can check it with the x-rays. Sometimes if there is very high inclination or sinking of the implant or gross mismatch, that can be checked on the x-rays. But proper component alignment can be checked on the CT scan. As you can see in these slides, you can check the anteversion, you can check the inclination of the cup, and also you can check the anteversion of the femoral component in the CT scan. Now coming to the safe zone, where the cup should be. Although the concept of safe zone is changing nowadays, but we should try always to keep our cup in the safe zone. Safe zone for the acetabular cup is the inclination is about 40 plus minus 10 degree and anteversion of 15 plus 10 degree. The new concept of combined anteversion is better than the actual one. So combined anteversion is the anteversion of the cup plus anteversion of the femoral component. Preferably, it should be 35 degree. The range should be 25 to 50 degree. This test can be done in posterior approach through coplanar test or the Ranawat test. So in this test, the head and the cup should be lined, and we should rotate the limb in such a position that cup and head should align each other. And at that point, what the leg makes an angle with the horizon, is the anti-version, combined anti-version. This is co-planar test suggested by Ranawat. Now coming to the head sides, whether we should use the small size head or large size head, do it have any effect on the dislocation? Yes, larger head have large jump distance, increased range of motion, and less impingement. But this comes with the high erosion rates. So that any head larger than 36 should not be used. Larger head reduce the chances of dislocation, but it carries the risk of polythene thinning, and also the size of the poly reduces with these large heads. Impingement is one of the important factor which usually we miss. So how it works? It serves as a fulcrum to dislocate the hip in the direction opposite to its location. Whether it is anterior, that it will dislocate posteriorly, or if it is posterior, it will dislocate anteriorly. So what things can do the impingement? Bone or cement protruding beyond the flat surface of the cup. There could be the residual osteophytes, especially anterior-inferior part. Capsular scar tissue, if it is very hard, can act as an impingement. Heterotropic ossifications and impingement of femoral neck on liner elevation. Suppose we use the elevated liner, then neck itself can act as an impingement. Another important thing along with the safe position is the soft tissue tension. So we have to maintain the hip offset, combined hip offset, both. What we call is global offset also. The femoral offset plus acetabular offset. Femoral offset is the distance between the longitudinal axis of the femur within and the head center. So it is a femoral, and the acetabular is taken from the center of the acetabular cup or head to teardrop point. So this should match on both the sides. So we should try to maintain the global offset of the hip. Meticulous soft tissue repair is also targeted, and restoration of limb length. This all cause soft tissue, proper soft tissue tensioning. This reduces the chances of dislocation. Very tight hip, suppose there is the lengthening and it is very tight, then it also has the chances of dislocation. If it is very soft, then it also has the chances of dislocation. So what to do when we encountered a case of dislocation? So first thing what we should do is try to do is the close reduction under anesthesia. Anesthesia is a must. One gentle attempt should always be taken. Success rate is more than 2/3 of the cases, while it may fail in 1/3 of the cases, where you have to go for the open reduction. So whenever you plan for the open reduction, everything revision should be ready. Then you go for the open reduction. And in the meanwhile, you check what's the problem with it, whether the component malposition is there or soft tissue tensioning is less. So you have to find out the cause and then go for the open reduction and try to correct it on the first go. If it reduces in position, physical examination is must. Hip range of motion, limb length, abductor muscles, everything is checked, stability is checked, and limb is kept in the abducted position with the use of brace. If it dislocates again, then we must think of the causes, then correct the causes which can be detected: component malposition, impingement, inadequate soft tissue tension. Revision surgery should be planned. We can revise the component, exchange the modular component, like we can increase the size of the head, we can increase the offset of the head, we can change the acetabular liner. Suppose elevated liner is causing the impingement, we can go with the neutral liners, or we can change to the bipolar or tripolar arthroplasties. Dual mobility heads, larger femoral head could be used. Soft tissue reinforcement or advancement of the greater trochanter can be done. And at last, if we find something is not working, we can use the constraint liner also. So coming to the dual mobility cups, they have different subset of problem with the dislocation. So if you see a kind of what we call it halo sign. Halo sign means if you can see here in the screen, the outer liner is in the place. One general attempt can be given. If it reduces, it's okay. But if it doesn't reduce, and if you can find these bubble outside it, or the head is not in center of the cup, then there is chances of intraprosthetic dislocation. So in this case, we have to go for the open reduction. Or straightforward, if you see that head, smaller head and the outer polythene both are dislocated, what it is called bubble sign. If you can see this in the primary first x-ray, then open reduction is the only choice. So dual mobility carries a different set of problem when it dislocates. Coming to some of the example, this is one of the cases. Multiple surgeries have been done. First THS was done, then infected, then implant removed, then THR was done. Everything was looked good. Abductor mechanism was restored. But these cases, just the purpose of showing this is that these cases carries the high chances of dislocation. So it dislocates again, and there is disruption of the abductor mechanism, although is managed with the close reduction. Another case with subsequent dislocations, here you can see we use the constrained liner. So sometimes we have to use this constrained liner to avoid further dislocations. Thank you.
Thank you very much, Ratnesh. That was very precise and brief, but really covered all the causes of dislocations and what you do in those situations. I'm sure there'll be some questions from the delegates, so we'll open it to that.
So, thank you very much, sir. Sir, one thing which uh, we should taken care of while we are operating. What are the 2 to 3 important points, sir, we should take care to prevent further dislocation?
First thing is we should see the physically whether the patient's neuromuscular status is okay or not. Second thing, if it is a revision surgery, we should plan accordingly because there is high chances of dislocation. So during surgery, two important thing is there. First is to get the cup in the safe zone. Although safe zone also dislocates, that could be due to the improper soft tissue tensioning. So soft tissue tensioning, limb length inequality, and global restoration of the offset is very important. If you combine all the things, then there is less chances of dislocation. If you find it that it is a high chances, then you can go for the dual mobility cup or constraint cup straightforward.
Sir, if someone is having hemiplegia on that side, if we are operating, means there is more chance of dislocation, right, no, sir? If
Yeah,
muscles are weak.
in cases of hemiplegia, if a total hip is planned, then it should be the constrained one. But you have to check whether he required total hip or not, because the purpose of doing the total hip is to mobilize the patient properly.
I think there's a question on jump distance from Anand.
Yes, sir.
Ratnesh,
Sir,
someone
Jump
wants to know,
distance, sir.
Anand wants to know what is
jump
jump
distance is a
distance?
distance of the head which is required from the center of the head to the corner of the cup is a jump distance. If the cup crosses that distance, then only it goes out on the dislocation. So the jump distance increases when you increase the larger size of it.
So
Does that
when
answer your
we
question,
have,
Anand?
sorry, sir.
Whoever asked that
Anand,
question, does that answer it?
Sorry, sir.
Anand? Okay, maybe he's not able to unmute, sir.
Okay.
Yes, sir.
Yeah, it's
So,
answered your question. Yeah. Okay. Any other questions?
so I think
So let's ask the delegates the questions now, since they don't have any questions. So what is the most common cause for a dislocation in a total hip replacement?
Most common cause is
Who
the
are the
component
delegates?
malposition, I think.
from delegates, sir.
Yeah, I'm asking the delegates.
Yes. Anand, Kamran, and Rajan is there. So,
Component malposition
it's
is one
us.
of the common cause. The high
Ratnesh has
inclination.
already answered it, unfortunately. That was meant to be for the people who are listening, Ratnesh.
Yes.
Increased inclination of the cup is, I think, one of the most common cause. If the
Yeah.
cup is in like more than 55 degrees, which is usually in the posterior approach, is one of the most common cause for dislocation.
Okay, so if there are no further questions, thank you very much, Ratnesh. And until next week, this was finished rather earlier than usual, so never mind. But we'll have the next meeting on the Tuesday again. So over. Okay,
Okay.
thanks a lot.
Thanks.
Okay. Sir.
Thanks.
Thanks. Thanks, Janki.